Hello, everyone. My name is Jens Juul Holst. I'm a professor of medical physiology at the Novo Nordisk Foundation Center for Basic Metabolic Research and the Department of Biomedical Sciences at University of Copenhagen. And I'm here to discuss the discovery of GLP-1 and some recent results with the GLP-1 receptor agonists. And that's what we will do. So what is GLP-1? GLP-1 is a product of intestinal proglucagon expression. So the proglucagon gene that's shown, the product of that is shown on top. And then you can see that the proglucagon gene is expressed in the pancreas, where it gives rise to glucagon here, and this large peptide, which is probably inactive. But in the gut, the gene is also expressed. And here it doesn't give rise to glucagon, but to this peptide, which is called glycinin, where glucagon is buried, but it's also inactive, most likely. But this part of the proglucagon molecule is then cleaved to release GLP-1, glucagon-like peptide 1, and glucagon-like peptide 2. Glucagon-like peptide 2 is very interesting, but we don't have time to discuss this today. We will concentrate on GLP-1. So GLP-1, what is it? What did it do? It was isolated using its effect on insulin secretion in these studies with isolated perfused pig pancreases, where we were able to chase the insulin secretion of extracts from the gut, and in this way isolate the molecule GLP-1. And here you see the results of this. So what you see is that at different glucose concentrations, the results are very different. So insulin secretion stimulated by different doses of GLP-1 here at low glucose do not do anything to insulin secretion, but at normal glucose levels, there's a nice effect here. And then at higher concentrations of glucose, there's an even stronger effect on insulin secretion. And that means, of course, that the effect is glucose dependent. And also it means that you cannot immediately produce hypoglycemia with GLP-1, which is interesting. Now, stimulating insulin secretion was at the time interesting, of course, but not sensational. There were many peptides from the gut that would stimulate insulin secretion, so that was perhaps not a revolution. But this was new. That is inhibition of glucagon secretion from, again, the isolated perfused pancreas, where you can see that GLP-1 in various concentrations very profoundly inhibited glucagon secretion. And this is important because of these actions, it was possible to do something about the hypoglycemia of people with type 2 diabetes. And this was really the decisive study where this was really cemented. And what you can see here is that infusions for 4 hours of GLP-1, synthetic GLP-1 here, took down glucose concentrations in patients that were allowed to hospital with very high glucose concentrations down to completely normal levels within 4 hours. And this happened while it was stimulating insulin secretion, as shown here, and inhibiting glucagon secretion. And you can also see that as glucose concentrations were normalized, the effect on insulin secretion stopped, and also the inhibition of glucagon secretion. So this was really the start of the diabetes therapy with GLP-1. And another very important study is shown here. That was the study from 2002, where GLP-1 was given to people with diabetes continuously as a subcutaneous infusion for 6 weeks. And the reason for doing this, of course, was to see if there was tachyphylaxis. Would it act? As I will show you in a minute, GLP-1 is eliminated very, very quickly. So would it continue to act continuously for these 6 weeks? And what we found was that it reduced fasting and mean plasma glucose by very large measures here, 4 and 5 and 6 millimoles per liter. That it also reduced hemoglobin A1C levels by 1.3% in 6 weeks, which is really a lot. It also had a weight loss of 2 kilograms because of significantly reduced appetite. It also improved insulin sensitivity and grossly enhanced beta cell secretion. And in this study, there was no significant side effects at all. So how good are the GLP-1 receptor agonists for diabetes therapy? And let me show you this very recent study here with a GLP-1 receptor agonist, which is called tirzepatide. I'll come back to what it is. Here is the registration study called the SURPASS-2 study, where people with diabetes, a large number of people, were studied for 40 weeks with a weekly injection of tirzepatide. And you can see from this graph that more than half of the patients treated with 15 milligrams of tirzepatide reached an A1C level less than 5.7%. 5.7% and less is, of course, normal levels. And this really means that you can more or less normalize the glucose levels of these individuals with a GLP-1 superagonist. And that is really a sensation that has never been seen before. Another important factor came up from the studies where we were looking at the various effects on the GI tract and what have you of the new peptide GLP-1. And here we're looking at food intake and appetite. And to the right, you can see that between meals, if you register satiety, you will have increased satiety when you're also infusing physiological amounts of GLP-1. And you will have lower hunger ratings between the meals when you infuse GLP-1. And as a result of these changes, you also have a decreased food intake. So this was the food intake at a subsequent ad libitum meal. And you can see that there is a significant reduction in the food intake when GLP-1 was infused. This shows a number of studies, an early compilation and meta-analysis of a number of studies looking at GLP-1 infusion rates and also the decrease in food intake and energy intake. And you can see that there is a linear relationship. And what this shows you, which is quite important, is that the effect on food intake is dose-related. The larger the dose, the greater the amount of GLP-1 you can infuse, the more you will inhibit food intake. And let's remember that when we move on in these slides here. So GLP-1 was, of course, of extreme interest for the therapy of type 2 diabetes and perhaps also obesity. But the problem is that GLP-1 in itself is very, very unstable. So it is attacked by this enzyme dipeptidyl peptidase 4, DPP4, which cleaves off these two N-terminal amino acids. And the remaining part here is completely inactive in terms of insulin secretion and food intake. And this happens with a rapidity of 1 to 2 minutes. The half-life due to DPP4 is 1 to 2 minutes. So that is, of course, extremely rapidly degraded. And there's another problem, and that is if this was not big enough, this problem, then the kidneys are also removing a large amount of GLP-1. So the clearance of the kidney is very high, and the half-life due to the elimination in the kidneys alone is as low as 4 to 5 minutes. So something had to be done before these molecules could be used for treatment of either obesity or diabetes. And so a number of molecules were developed based on the structure of exendin, because it is not specifically cleared in the kidneys and it's not sensitive to the actions of DPP4. But still, it is filtered in the kidneys. So these compounds are short-acting with an intravenous half-life of 30 minutes. And for various reasons, they are not so good as the other peptides, even if exenatide has been administered in a weekly preparation also. Another solution to the problem is to make them long-acting. And in this case, it was done by attaching a fatty acid to the molecule. Then the molecule will bind to albumin in the circulation and avoid renal elimination, be protected against DPP4, and therefore it all of a sudden had a half-life of 12 hours. With a different fatty acid and a different spacer, and a protection here, it was possible to bring this to a half-life of 1 week. Dulaglutide over here, their GLP-1 was coupled to a large molecule, in this way eliminating renal elimination. It also had a half-life of 1 week. And tirzepatide down here is also a very, very interesting peptide. Although it is a GLP-1 co-agonist, it is prolonged because of acylation, attachment of a fatty acid here that makes it bind to albumin. And let's have a look at some of the results here. So I must mention that there are also now oral GLP-1 receptor agonists. And actually on the market, we already have oral semaglutide, Rybelsus, at the doses of 2, 7, and 14 milligrams. And we're soon, I'm sure, going to see the 25 milligram dose of daily doses being used. It is very effective, as was demonstrated in the phase 3 trials and published in the New England Journal of Medicine. There is also a completely different compound, namely a small molecule, a chemical entity called orforglipron. Here at 3, 12, and 36 milligrams daily, it also had a very pronounced effect, and the phase 3 studies were revealed very, very recently in May in the New England Journal of Medicine. I will show these data just to illustrate what I think about the combination of GIP with GLP-1. So this is a study where we gave semaglutide to people with diabetes, and then on top of that started a 6-week-long infusion of GIP to see what would happen. And you can see here, looking at the glucose levels, that whenever there was GLP-1 semaglutide, in this case, around, then there was a very nice suppression of glucose concentrations here. But the addition of GIP alone didn't do anything. An addition of GIP to semaglutide also didn't do anything. And over here, you can see the body weight change in the same individuals. As semaglutide was given, there was a decrease in body weight, of course, as expected. But the addition of GIP either to semaglutide or alone did not really influence obesity or body weight at all in these studies. And this is what I'm going to say about the combination of GIP and GLP-1. But the results with the GLP-1 receptor agonist are really stunning. So here we have one of the major important studies, and this was the registration study for semaglutide, the SUSTAIN-6 trial, where we are looking at MACE, major adverse cardiovascular events in people with type 2 diabetes. And you can see that over this 2-year study, in this large 2-year study, there was a reduction by 26% in the occurrence of MACE. A very recent compilation of all the studies that have been done with all the GLP-1 receptor agonists here is shown in this slide, where you see the forest diagram. And if you're to the left of the unity line here, there's a beneficial effect on cardiovascular complications on MACE. And you can see that this is true for all of the studies, that they have a nice effect on MACE. Also, the combined effects here, the overall effect. 2 of these compounds are sticking out a little bit. That is exenatide derivatives. This is the elixir studies with lixisenatide here, and this is the infused with mini pumps exenatide here. They did not do it, and for various reasons, but it has taken away some of the interest for the exenatide-derived compounds. So here we are looking at the effects of semaglutide on people with heart failure in the SELECT trial. The SELECT trial was a huge trial in people without diabetes, with obesity and some markers of heart disease. And here we're looking at the results of individuals with heart failure or without heart failure during the course of this treatment for no less than 4 years. And you can see that those that had heart failure had a very much reduced frequency of MACE, major adverse cardiovascular events. Those without heart failure also had a beneficial effect of the treatment. And if you look at the groups with a reduced ejection fraction, there was a very nice effect here again on MACE. And also, if you look at those with preserved ejection fraction, there was a very nice effect. So unlike what was expected from the semaglutide treatment, there was a very beneficial effect on individuals with heart failure in this very large study. Here is another study where we're looking at something different, namely the occurrence of dementia. And this is a large Swedish study where the occurrence of dementia during a very long period of 130 months here was looked at in people treated with semaglutide or other glucagon like GLP-1 receptor agonists, and compared to DPP-4 inhibitors and sulfonylureas. And you can see that there was a very strong reduction in the occurrence of dementia in this study. And this has been looked at in even a more convincing way here in this systematic review and meta-analysis from April 2025, where no less than 26 randomized controlled trials were looked at, and comprising 160,000 individuals. 10 of them were trials with glucagon-like receptor agonists, and 12 of them were SGLT2 inhibitors. Overall, in this very large study, there was no effect on a reduction of dementia. But if you looked at the GLP-1 receptors alone, there was a reduction by 45%, very significant. And whereas with the GLP-2 receptor inhibitors, there was no significant effect of the inhibitors. So you can see the graphical representation of the data over here with a very convincing effect of the GLP-1s. Here is another one. That is the occurrence of dementia-related, or Alzheimer's-related dementia in people with type 2 diabetes. And again, we're looking at a very large material of people in a 3-year follow-up study where semaglutide was compared to treatment with insulin, with metformin, and with the older GLP-1 receptor agonist. And here you can see the very strong reduction in the risk of developing of dementia during therapy with semaglutide compared to insulin and compared to metformin and to the older GLP-1 receptor agonists. This is a very important study in people with diabetic kidney disease. Again, a very large study of 3,500 people where semaglutide was studied and over the course of several years here. And the result was that there was a reduction in the kidney disease progression as well as in cardiovascular and kidney deaths by 24% compared to placebo. And let me show you some of the results here. Here we're looking at the kidney disease events here. Here we're looking at cardiovascular causes, deaths. Here, MACE. And here you're looking at deaths of any cause. In all cases, a very strong, significant reduction in the risk. But what I really want to show you here is something that was a new experience. That was the development of impairment of kidney function. These individuals with diabetic kidney disease, they show a reduced glomerular filtration rate with time, as you can see here. But that decrease, that impairment in glomerular filtration rate, that is in kidney function, can be halted somewhat with semaglutide, very significantly actually. And that is, of course, an extremely important observation. Here we're looking at people that are treated with GLP-1 receptor agonists, or GIP, that is the tirzepatide one, and a very large retrospective cohort study here, where in very large numbers of patients with opioid abuse disorders and also with alcohol use disorders here, 800,000 of them here. And you can see here that those that were treated with the GLP-1 receptors had a lower rates of opioid overdoses, a reduction by 40%. And those with alcohol intoxication were reduced by 50%. And that is interesting in relationship to the actions of the GLP-1s. I'll come back to that. Here we have it. So what are the actions? And here we have all the known actions on the kidney, on the heart, on the platelets, on the intestine, the stomach, the liver, the pancreatic islets. But what I really want to point out here is the effect on blood vessels, which we also have. And that's where receptors are expressed, and where experimental studies have indicated a very beneficial effects and an effect on the development of atherosclerosis by GLP-1. And another important thing is the effect of inflammation. So diabetes and obesity are associated with a low-grade systemic inflammation, as you know. And if you look at the markers of this inflammation, for instance, CRP, they're very significantly reduced during therapy with a GLP-1 receptor agonist. So you have a beneficial effects on the vasculature and on inflammation. And both of these are, of course, common to all the organs and can therefore explain the diffuse but great effect of the GLP-1 receptor agonist. On top of that comes the effect on food intake, on appetite, and on obesity, the weight loss that you experience. And this is illustrated here, semaglutide, where we're looking at the weight loss in the step 4 trial. And you can see a very pronounced decrease in weight loss over these 68 weeks. And this was really the changing moment for the GLP-1 receptor agonist, because this for the first time showed that the weight loss was at a magnitude that corresponded to the expectations of the patients. Very nice results. And semaglutide was then studied in a cardiovascular outcome trial in obese individuals, in 17,600 of them for up to 40 months. And the result was that there was a reduction by 20% in cardiovascular events in the MACE risk in this study. So that means that these people with a metabolic syndrome, with the complications of it, actually can be treated with this, so that it doesn't only apply to people with diabetes. Here's another very important result obtained with tirzepatide in the SURMOUNT-4 registration trial. And over these 88 weeks, you can see that there was a weight loss of no less than 26% in this study. But here is another set of results from the SURMOUNT-1 trial. Again, with tirzepatide, 15 milligrams. The SURMOUNT trial was extended by 2 additional years. So we have a 3 years observation period. And in that, there was a very nice weight loss, as you can see, 22.9%. But the important thing is that the risk of developing type 2 diabetes, which is very high in people with overweight and prediabetes, of course, was almost completely eliminated, reduced by 94% in these individuals. That is extremely important. Here's another important observation regarding the problems with obesity, and that is the obesity-related cancers. And here is a study where 13 of these obesity-associated cancers were looked at, and 10 of them showed a very significantly reduced occurrence. For instance, colorectal cancer shown here during the therapy with GLP-1 is very much reduced, and liver cancer was also very much reduced during the therapy with GLP-1 receptor agonists. So what is going to happen with the GLP-1 receptors? One peculiar observation is that very few stay on therapy. And here, in this case, it was 40% that stayed on therapy 1 year after the prescription of a GLP-1 receptor. Why is that? One observation is, of course, that all patients stop taking their medication. So that explains some of it. A very important reason could be the costs. They are expensive. They will become cheaper, but that is important. Some people may stop when the desired weight loss has been obtained, and what happens then depends on how you are prepared for that. In many cases, you will not be able to maintain the weight loss, as I showed in some of the previous slides. For some people, there will be side effects: nausea, vomiting, diarrhea, stomach pain, and that may lead to termination of therapy in some cases, let's say around 10, maybe up to 20% in some cases, but it's not a major cause of it. But here's another interesting thing: that is the reward effect, the feeling of pleasure once you have, for instance, eat, the reward of meal intake, which is inhibited by GLP-1 receptor agonists. And this probably also explains the effects on opioid misuse and alcohol misuse, that you have this effect on reward. But it will also probably limit the use of the GLP-1 receptor agonists, because if the pleasure of eating is one of the greatest pleasures in life, and somebody all of a sudden takes this away from you, you're not going to be very happy. So here's a very important thing during therapy with the GLP-1 receptor agonist. During this up-titration of the dosing, which may take up to half a year or even more, it's very essential to use this period for lifestyle changes. You should not sit in a leaning chair waiting for the fat to melt off. It's important that you change habits, both dietary habits and exercise habits. And the dietary habits is for maintaining the weight loss after you've reached the desired weight. And the exercise habits is also to support the weight loss, but certainly also to prevent the loss of lean body mass. So in some of these individuals, lean body mass is already low once you start the therapy. And if you then lose lean body mass, not specifically because of the GLP-1s, but because of the weight loss, then you're in trouble. You may be in trouble. So that's why you should enhance your physical exercise patterns and do something about it. All it takes is a daily walk by about 30 minutes, but it's important to do it to maintain the lean body mass. So that's what is said here. If you're able to use these changes, then you're also able to support and sustain the weight loss after termination of therapy in some cases. So my overall conclusion is that GLP-1 was discovered as an insulinotropic hormone, but it also inhibits glucagon secretion, which is one of the secrets behind its anti-diabetic effect. It also inhibits food intake and appetite and leads to major weight losses, and GLP-1 receptors agonists are therefore effective in obesity and diabetes. They have, as I've indicated, protective effects on the cardiovascular system and offer renal, neuro, and liver protection. And there's no doubt that the GLP-1 receptor agonist will be changing obesity and diabetes therapy in the future. So thank you very much for your attention.